If you touch a hot stove, your hand flinches before you even consciously register the heat.
Right. It's a completely brilliant protective reflex.
Yeah, but what happens when your brain learns to flinch like an hour before you even step foot in the kitchen? Today, for you listening, we're doing a deep dive into this wild medical phenomenon where just the mere anticipation of pain literally alters human anatomy.
It really is a profound example of how, inseparable the brain and the body truly are. We're looking at a space where traditional binary medical thinking, like categorizing things as strictly physical or strictly psychological, it just completely falls apart.
Totally. And since you're a dedicated learner, I think you're going to find this journey absolutely fascinating. We've got a pretty dense stack of sources today. We're pulling from clinical guidelines, heavily featuring the British Menopause Society consensus statement and the NICE-E guidelines, alongside some really detailed medical journal reviews and specialized clinic FAQs.
Yeah, and the mission for today's deep dive is highly specific.
Right, so we are answering this exact question. What specific cognitive behavioral techniques help a patient overcome the reflexive pelvic floor muscle bracing that is caused by a fear of dryness-related pain? Okay, let's unpack this.
It's a super specific intersection, I know. But understanding it unlocks just so much about how human pain actually works. But to understand the psychological tools, we first have to map out the physical trigger.
Because it's not just made up.
Exactly. The cycle always starts with a very tangible physiological change, typically tied to dropping estrogen levels.
Right, and the clinical term I kept seeing over and over in the British Menopause Society guidelines is Urinary syndrome of menopause, or GSM.
Yes, GSM. So when estrogen drops, which is just a totally natural part of perimenopause and menopause, the actual physical architecture of the vaginal tissue undergoes this dramatic transformation.
Like it physically changes shape.
Literally, yes. In a high estrogen environment, the vaginal mucosa is robust, it's thick. The surface layer is made up of these superficial epithelial cells. You can think of these cells kind of like microscopic water balloons.
Okay, water balloons.
Yeah, they're plump and they constantly shed. And as they shed, they release glycogen.
And that glycogen, if I remember right, is basically food for the healthy bacteria, the lactobacilli, which, keeps the environment acidic and fights off infections.
Precisely. It's this beautiful, self-sustaining ecosystem. But when estrogen plummets, that crucial mucosal layer thins out severely. The population of those plump water balloon cells decreases to less than 10% of what it was.
Oh, wow. Less than 10%.
Yeah, natural secretions just virtually disappear.
Yeah.
And structurally, below the surface, the collagen fibers that give the tissue its stretch, they actually begin to fuse together.
So the tissue is literally losing its elasticity. It becomes rigid.
Yeah, it does. So when penetrative sex is attempted, it's no longer just, slightly uncomfortable. It is physically damaging. It's like trying to stretch dry tissue paper.
Okay, I have to stop you there because if I'm a patient hearing this, I'm genuinely frustrated right now.
I get that.
Right? Because you just described tissue that is fundamentally altering. Collagen fusing, cells disappearing, elasticity vanishing to the point of literally tearing. And yet our mission today is to discuss cognitive behavioral therapy.
Yeah.
I mean, how on earth is a psychological model going to fix tearing tissue? It sounds almost dismissive, like telling someone with a broken leg to just think positive thoughts.
That is exactly the pushback patients give, and honestly, it is a completely valid reaction. This is where we need to introduce the fear avoidance model. You're absolutely right. Therapy does not fix tearing tissue. The initial pain is a 100% physical consequence of estrogen loss.
Okay, so then what?
Because humans aren't simple machines. When a person experiences repeated severe pain during intimacy, the mind and the nervous system learn to expect danger. I mean, the brain is an incredibly highly evolved prediction machine.
Right, so once the brain associates the act of intimacy with agonizing pain, it starts reacting before the physical event even happens. It's bracing for impact.
Yes, exactly. The brain's primary job is to protect the body from harm. When it predicts pain, it disrupts the entire physiological arousal response. Normally, the arousal cascade causes blood to flow to the pelvis, the vagina to lengthen and relax, and, natural lubrication to occur.
But anxiety just kills that.
Completely. Anxiety is a biological opposite of arousal. Anxiety activates the sympathetic nervous system that's your fight or flight response.
The alarm bells ring and the whole arousal process is just completely shut down.
Loudly shut down. And this anticipatory tread leads to intense hypervigilance. The autonomic nervous system bypasses conscious thought entirely and triggers these exaggerated defensive muscle contractions in the pelvic floor.
So it's that flinch reflex we talked about at the start, but sustained.
Exactly.
Hmm.
So the next time intimacy is even attempted, the pelvic floor muscles are already braced. They're clamped shut to guard against the anticipated injury.
Which mathematically guarantees that the pain is going to be infinitely worse. I mean, you're forcing friction against not only dry tissue, but a rigid, spasming muscle wall.
It's a devastating feedback loop. The physical tissue changes cause pain. The pain causes fear. The fear causes involuntary muscle bracing. And that bracing causes even more pain, which reinforces the fear for next time.
Wow.
Yeah, you're no longer just dealing with an estrogen deficiency. You're dealing with a deeply ingrained neuromuscular reflex.
Okay, so if I'm understanding the mechanism, it's kind of like a tripped circuit breaker in an old house. The original short circuit, the tissue dryness might have started the problem, but now the breaker is stuck in the off position.
That's a great way to look at it.
Right, so you can apply all the localized moisturizers you want, but if the muscles are clamped shut in terror, the electricity still isn't flowing. It's still going to hurt.
That is a perfect analogy. The physical trigger started the fire, but the nervous system is now throwing gasoline on it. The alarm system itself requires a systemic reset. And this is exactly where cognitive behavioral therapy, or CBT, enters the clinical picture.
But we need to address the elephant in the room that the clinic FAQs highlighted. When a doctor suggests CBT for pelvic pain, the patient almost immediately hears, "Oh, my doctor thinks this is all in my head."
Which is such a tragic failure of communication in modern medicine. Using CBT does not mean the pain is imaginary.
Right, the pain is very real.
Demonstrably real. But CBT is a highly practical tool designed to dismantle that secondary problem, the pain-related fear and the resulting anxiety cycle. What's fascinating here is how CBT targets what the literature calls maladaptive sexual scripts.
And a script being like the internal monologue and the set of unconscious expectations the person carries into a situation, right?
Yes, and think about how quickly those scripts solidify. When someone has experienced repeated agony, their internal script becomes understandably catastrophic. CBT helps the patient step back and observe that internal monologue objectively.
Yeah, the sources give some really visceral examples of these cognitive distortions. Like a patient might develop thoughts like, my body is broken, or I am going to tear and bleed profusely, or even just, this is always going to be agonizing no matter what.
Right. And CBT provides a framework to actively challenge those thoughts.
Yeah.
It asks the patient to look for evidence, like, are they definitely going to tear? Is it always agonizing every single time? It moves the brain away from that all-or-nothing catastrophic thinking and replaces it with a more nuanced, realistic appraisal.
And the literature also notes that cognitive restructuring is frequently augmented by ACT acceptance and commitment therapy. I actually want to dig into how this differs mechanistically from CBT, because normally when we anticipate pain, our instinct is to fight it, right? We tense our shoulders, we hold our breath, we brace for impact.
Which, as we just established, causes the pelvic floor to clamp down harder, directly causing more pain.
Right.
ACT flips the behavioral script entirely. Instead of fighting the sensation, which paradoxically increases nervous system arousal, ACT trains the patient to work with the sensation.
Wait, how does ceasing to fight actually lower the arousal?
Well, when you fight a sensation, you're sending a signal to your brain that the sensation is dangerous and requires a defensive response. When you accept it, when you essentially say, I feel pressure right now, and that is okay, you stop feeding the fight or flight loop.
Oh, I see.
Yeah. Acceptance in ACT doesn't mean resigning yourself to a lifetime of pain. It just means accepting the reality of the physical sensation in the present moment without attaching panic to it. And then the commitment part focuses on choosing behaviors that align with personal values, like a desire for closeness, rather than letting fear dictate every action.
Okay, so changing the internal monologue stops the cognitive panic. But you still have a pelvic floor that is physically trapped in a defensive posture. I mean, changing your thoughts doesn't magically melt a muscle spasm. How do you physically convince a hypervigilant muscle to just stand down?
You have to provide the nervous system with physical, undeniable proof that the environment is safe. And you do that through systematic desensitization, specifically gradual exposure therapy.
So you're confronting the feared stimulus, but in a mathematically controlled way.
Exactly. If jumping straight into penetrative intercourse is a level 10 on the anxiety scale, you do not start there. You start at a level 1. The behavioral technique most frequently cited in the literature is the use of vaginal trainers, which are commonly called dilators.
Right.
These are smooth, graduated rods, usually made of medical-grade silicone.
And the critical mechanism here, as I understand it, is that the patient is the one holding them. They are in complete control of the speed, the depth, the pressure.
Yes, control is the antidote to fear avoidance. The patient begins with the smallest size, in a totally safe environment, completely alone. This creates a new sensory feedback loop between the vaginal wall and the brain.
Because they're feeling the touch without the agony.
Exactly. As they experience this physical touch and pressure without the severe pain they anticipated, it provides tangible data that disproves the catastrophic expectation. The brain literally rewires its prediction model, learning, oh, penetration does not automatically equal tissue damage.
It's like rebuilding trust with your own anatomy.
Exactly.
But if the dilators prove to the brain that the physical space is safe, how do you handle the interpersonal pressure? Because having a partner in the room changes the entire psychological dynamic. The sources bring up this fascinating protocol for couples called a sensate focus program. And the very first rule of this homework is a strict clinical ban on intercourse.
I know, it sounds incredibly counterintuitive if the ultimate goal of the patient is to resume intercourse, right? But mechanistically, it is brilliant. By having a medical professional officially ban penetration, you completely remove the finish line.
Which takes the pressure off.
Exactly. You eradicate performance anxiety and that looming fear of pain from the equation entirely.
So what does that homework actually look like in practice?
Well, sensate focus is a highly structured, phased approach to touching. In week 1, it might involve only non-genital touch. The couple is instructed to touch each other's shoulders, arms, or backs. And the vital instruction is that the goal is not arousal.
Just feeling.
Right. The goal is purely to focus on the physical sensation of the texture of the skin, the temperature, the pressure.
So you're retraining the brain to experience touch as just touch, not as a precursor to pain?
Yes. And slowly, over a period of weeks, the phases progress to include genital touch, again with the strict boundary that it will not lead to penetration. This structured exposure rebuilds comfort with physical intimacy. It allows both partners to reconnect and experience pleasure without the dark cloud of anticipated agony hanging over the encounter.
That makes profound sense. Now, here's where it gets really interesting. Alongside this, the behavioral tools highlight mindfulness, and I think there's a big misconception here. We often picture mindfulness as, sitting passively with a candle trying to empty your mind. But in the context of pelvic floor bracing, mindfulness is a highly active somatic intervention.
It is a profound physiological tool. Mindfulness in this clinical setting usually involves deep diaphragmatic breathing and progressive muscle relaxation. It targets the autonomic nervous system directly.
Let's look at the mechanics of that, because the diaphragm and the pelvic floor are essentially a linked mechanical system, right?
They really are. They're the top and bottom of your core cylinder. When you take a shallow chest breath, which is, by the way, very common in people dealing with chronic pain and stress, your shoulders rise and your abdomen stays tight. But when you take a deep diaphragmatic breath, often called belly breathing, the diaphragm muscle physically descends.
And because it descends, it pushes the internal organs downward, which forces the pelvic floor to naturally lengthen and yield to accommodate that pressure.
Exactly. And then when you exhale, the pelvic floor gently recoils upward. By retraining the patient to breathe diaphragmatically, you are mechanically forcing the rigid pelvic floor to move, to stretch, and participate in the respiratory cycle.
Wow, okay.
Furthermore, this somatic mindfulness teaches the patient to anchor their attention in the present moment. Instead of the brain jumping 5 steps ahead to the catastrophic prediction of pain, the patient focuses purely on the physical sensation of their belly rising, or the specific feeling of a thigh muscle relaxing.
So they're actively learning how to command the muscle to release, rather than just trying to distract themselves from it.
Yes, they gain conscious control over what had become an involuntary reflex.
We've covered a massive amount of ground here. We've seen how cognitive tools challenge the catastrophic internal monologue. We've seen how behavioral tools use gradual exposure, structured touch, and breathing mechanics to physically disarm the tension. But every single clinical guideline we looked at is absolutely adamant about one thing: you cannot use these psychological tools in a vacuum.
Right, if we connect this to the bigger picture, CBT and behavioral therapies are only optimally effective when they are embedded inside a multidisciplinary care plan. As you pointed out earlier, you cannot just think your way out of severe estrogen deficiency. Psychological therapy shouldn't replace treating the physiological root cause.
So we pair the psychological with the physical. The sources list exactly how this integration works. While the patient is rewriting their pain script with CBT, they're simultaneously rehabilitating the tissue. This often involves localized topical estrogen. But the British Menopause Society statement highlighted another treatment that honestly blew my mind, vaginal DHEA.
Oh, DHEA is a fascinating intervention. It utilizes a biological mechanism called intrachronology.
Okay, let's double click on that. Intrachronology is not a term you hear every day.
It's a localized hormonal marvel, really.
Yeah.
DHEA itself is a precursor hormone. It's completely inactive. When it's applied locally into the vagina, specific enzymes that live inside the vaginal epithelial cells take that DHEA and convert it into active estrogens and androgens right there, inside the cell.
So it's essentially manufacturing the hormone on site.
Precisely. It rebuilds the vaginal wall, it improves collagen density, and restores natural secretions at the cellular level. But the real beauty of intrachronology is that the hormone is created, used, and then deactivated within that local tissue.
Oh, so it doesn't go everywhere else.
Right, 95% of it never enters the systemic bloodstream. You avoid the systemic spikes in hormone levels while completely remodeling the local environment.
That is targeted repair at its finest. And alongside the hormones and the cognitive therapy, this multidisciplinary approach almost always includes pelvic floor physiotherapy, right?
Yes. A specialist pelvic health physiotherapist is often the linchpin here. They use targeted manual techniques to release specific trigger points in the musculature that the patient just can't resolve on their own. And this brings us to one of the most brilliant intersections of all these therapies, combining behavioral relaxation with biofeedback.
Okay, this sounds very high-tech, but the mechanism is actually incredibly practical.
It bridges the invisible gap between the mind and the body. Biofeedback involves placing tiny, painless sensors in or around the pelvic floor to monitor the electrical activity of the muscles. The patient sits in front of a screen that displays a visual representation of their muscle tension. It's usually a jagged line graph or a rising bar.
So if the therapist asks the patient to simply imagine penetrative intimacy, the patient can literally watch the graph spike into the red zone as their autonomic nervous system involuntarily braces.
They can see their own fear avoidance reflex happening in real time. It completely demystifies the process. The bracing is no longer this invisible, terrifying mystery. It's just a data point on a screen.
That's incredible.
It is. And more importantly, as the patient utilizes the diaphragmatic breathing and the cognitive acceptance techniques they learned in ACT, they can actually watch that jagged spike smooth out.
They get immediate visual confirmation that their thoughts and their breath are actively changing their physiology.
They realize they possess the power to consciously override the reflex.
So what does this all mean for you? It proves that pain is deeply multifactorial. You treat the structural tissue dryness with localized intrachronology or estrogen. You treat the physical muscle knots with physiotherapy. And you treat the software, the fear avoidance reflex, and the anticipation of pain with cognitive behavioral techniques and gradual exposure. You systematically dismantle the cycle from every conceivable angle.
It is the absolute definition of a biopsychosocial approach. The biology of the tissue, the psychology of the fear, and the social context of the intimate relationship are all given equal weight and treated simultaneously.
It's incredibly empowering, honestly. We've spent this entire deep dive exploring a somewhat dark phenomenon, the fact that the human brain is powerful enough to learn to anticipate pain so vividly that it creates a physical, involuntary muscle spasm. The brain alters the body's reality based purely on expectation.
Which leaves us with a truly provocative concept to mull over. If the human nervous system is capable of learning a pain script with that level of physiological intensity, could we eventually leverage these exact same cognitive behavioral principles to train the body to anticipate healing, deep relaxation, and profound pleasure with that exact same physiological intensity? If the anticipation of danger can lock the door so securely, surely the anticipation of safety can be trained to throw it wide open.
That is a brilliant thought to end on. The mind isn't just a passenger, it is the architect of the experience. A huge thank you to you, our listener, for joining us on this deep dive into the fascinating mechanics of the human body. Keep questioning, keep exploring, and we will see you next time.